Inlet of thorax and intercostal muscles. So you can see the inlet of the thorax that is formed by first thoracic vertebra, then on either side by the first strip with costal cartilages and the jugular notch. So thoracic inlet is kidney shaped. It measures some 4 inches in transverse diameter and 2 inches anteroposteriorly. The boundaries of thoracic inlet are body of first thoracic vertebra, first strips, their costal cartilages, and upper border of the manubrium sternum or manubrium sterni. The inlet slopes downwards. There is 1.5 inch difference in height between the anterior and posterior extremities of the inlet of thorax. The upper border of manubrium is opposite the disc between the second and third thoracic vertebra. So the picture showing the jugular notch and the manubrium sterni and the first strips, and the line indicates the attachment of scalenus anterior muscle. The first rib is the shortest, flattest and the most curvaceous of the ribs. It has broader upper and lower surfaces and the sharp outer border and inner margins. Inner margin has scalene tubercle. Scalene triangle. Scalene tubercle provides insertion for the tendon of scalenus anterior muscle. Immediately in front of this tubercle, the upper surface of the first rib has a groove for subclavian vein. Because of the obliquity of the thoracic inlet, this vessel lies below or safely behind the clavicle. So, behind the scalene tubercle lies the second groove, which is for the subclavian artery and the lower trunk of the brachial plexus. Immediately behind this groove is the area for the insertion for the scalenus medials. So these 3 structures, that is the base is formed by the first strip, anteriorly it is by the scalenus anterior muscle and posteriorly it is by the scalenus medius muscle. Then we go to another, that is the Simpson's fascia. The inner margins of the first rib is attached to suprapleural membrane, or better known to clinicians as Simpson's fascia. It is a tough sheet of fibrous tissue which spreads out like a tent. From its origin, from the transverse process of the cervical 7th vertebra, forms a protective cover over the cervical pleura. Relations of the inlet. As you can see in the picture, subclavius muscle is anterior, then serratus anterior and intercostal margins and intercostal muscles are on the lateral margin of the rib. Inferior aspect is related to cervical pleura. Crossing the neck extrapleurally or medially, as you can see in the picture, the sympathetic trunk, and laterally anterior primary ramus of the first thoracic nerve passing to the brachial plexus. Then we come to inferior thoracic aperture. It connects thorax with the abdomen. Diaphragm occupies and closes the inferior thoracic aperture. Structures that pass between the two cavities either pass behind the diaphragm or through various major and minor openings in the diaphragm. The boundaries are posteriorly the 12th thoracic vertebra, body and transverse process. Posterolaterally it is by 11th and 12th ribs. Anterolaterally, the costal margins formed by the conjoint costal cartilages of 7th to 10th ribs, and anteriorly it is xiphisternal joint. So the apertures in the inferior thoracic aperture or the diaphragm are diaphragmatic apertures are at the level of T12 it is aortic hiatus, at the level of T10 it is esophageal hiatus, at the level of T8 it is venicoval openings, and apart from this there are lesser apertures. Then we go to intercostal muscles. Expansion of the rib cage. And the expansion of the rib cage and the abdominal wall are prominent features of inspiratory phase of breathing cycle. Expansion of the abdominal wall is produced by the action of the diaphragm. As the diaphragm is activated, its muscle fibers shorten, its dome moves down, pushing the abdominal viscera down and displacing the anterior abdominal wall outward. Intercostal muscles produce inspiration. During experiments, it was found that diaphragm acts alone produces an expansion of lower portion of the rib cage, but an inward displacement of the upper half of the rib cage. Normal expansion of the rib cage during inspiration is primarily produced by intercostal muscles. Intercostal muscles, they form two thin layers in each intercostal space. The outer layer consists of external intercostal muscles. External intercostal muscle extends from the tubercle of the rib to the costochondral junction. The fibers of this layer, that is external intercostal muscle, are oriented obliquely in anteromedial direction from rib above to the rib below. In contrast, the inner layer, the internal intercostal muscle, extends from sternocostal junction to near the tubercle of the rib. Fibers run in posterolateral direction as shown in the picture, from the rib above to rib below. Thus, an intercostal space contains two layers of intercostal muscles in their lateral portion only, but a single layer in their ventral and sometimes in the dorsal portion. There are parasternal intercostal muscles. Between the sternum and chondrocostal junctions, external intercostal muscle is replaced by fibrous aponeurosis called as anterior intercostal membrane, and the only muscle fibers are those of internal intercostal muscles. This portion of internal intercostal muscle, based on location and function, is conveniently called parasternal intercostal. The parasternal intercostal muscle is covered on their inner surface by thin muscle called transverse thoracis. The transverse thoracis fibers are oriented nearly perpendicular to those of parasternal intercostal and parallel to external intercostal muscles. Nerve supply of the internal intercostal muscles. All the intercostal muscles in a given space are innervated by corresponding intercostal nerve. Intercostal nerve sends many fine nerve branches or filaments along its course to supply the entire internal intercostal muscle, including the parasternal intercostal, the transverse thoracis, and several abdominal muscles. The main nerve trunk, therefore, is commonly called as internal intercostal muscle. Nerve trunk sends two large branches along its course. Near the angle of rib, the nerve sends a first large branch that perforates the internal intercostal muscle and then runs ventrally between the external and internal intercostal muscles. This branch innervates through a number of filaments the external intercostal muscle and is usually referred to as external intercostal muscle. The second large branch perforates both internal and external intercostal muscles about halfway between the rib angle and the costochondral junction and innervates the external oblique muscles of the abdomen. Action. External intercostal in the dorsal portion of the upper intercostal spaces have large inspiratory mechanical advantage. This advantage decreases in the ventral and the caudal direction such that it is reversed into expiratory mechanical advantage. Internal intercostals in the caudal spaces also have large expiratory mechanical advantage, but this advantage decreases in cranial direction and for the rostral intercostal spaces. Intercartilageous portion of the internal intercostal, the so-called parasternal, have a large inspiratory mechanical advantage, whereas transverse thoracic has large expiratory mechanical advantage. External intercostal muscles and parasternal intercostals are active only during inspiratory phase of breathing cycle. External intercostal activity is greatest in the dorsal portions of rostral intercostal spaces. It decreases both ventrally and caudally such that the muscles in the caudal spaces remain silent. External intercostal and parasternal intercostal. External intercostal and parasternal intercostals have inspiratory function during breathing, and coordinated activity between them elevates the rib and contributes to lung expansion. Internal intercostal. In contrast, internal interosseous intercostal and transverse thoracic are active only during expiratory phase of the breathing cycle. Internal intercostal and transverse thoracic are active only during expiratory phase of breathing cycle, and the internal intercostal activity is greatest in the caudal intercostal spaces. These two muscles therefore have expiratory function during breathing. They act in concert with the abdominal muscles to deflate the chest and the lung. Conclusion. The external intercostal and internal intercostals have opposite actions on the lung during breathing. These opposite actions are largely the result of selective regional activation of the muscles rather than different orientations of the muscle fibers as has been conveniently taught. Thank you.